of SPGA G0 or 1. This genital psoriasis symptom scale, or GPSS, was validated by Gottlieb and Alice Gottlieb and the group, which they published in 2018. It's nice because it's patient administered, assessing the symptoms of itch, pain, discomfort, stinging, burning, redness, scaling, and cracking, with a wide total score range, however, from 0 to 80, and may be useful in assessing before, during, or after treatment, in either in trials or even in routine clinical practice. Several quality of life assessment tools which may be used on patients with genital psoriasis, including, there are many, and they include even highly specific for sexual quality of life. However, the Dermatology Life Quality Index, or DLQI, remains the most utilized tool. As you probably know, it's simple. It's a validated 10-item questionnaire, and it touches on several domains such as symptoms of and feelings, daily activities, leisure, work, school, performance, and even personal relationships, which include a question of focused on sexual health. Proper skincare is essential for managing genital psoriasis and preventing flare-ups. Patients are advised to maintain good hygiene, use mild cleansers, and avoid products that can probably irritate sensitive skin. Wearing comfortable and breathable undergarments can also reduce friction and irritation. Prevention of infection and treatment as early as possible, if existing, is also a must. While sexual activity is generally not restricted, patients should be aware of the potential of aggravating factors. Topical therapies are the first-line treatment, and we usually recommended this mild to moderate genital psoriasis. As you very well know, you cannot use very, very potent steroids on this area because of the risk of atrophy, and prolonged use may be also a concern. And so one can shift after about 2 weeks of topical application to vitamin D analogs or calcineurin inhibitors, and they can offer some relief, but not as potent, of course, as psoriasis. You just achieve a good scoring system, a good parameter for improvement, and then shift to non-steroidals. Topical PDE4 inhibitors, also that's crisaborole and roflumilast, offer additional options, and therefore we should just understand, basically, that we have to ensure individualized treatment plans for optimal symptom control and minimal side effects. Certain treatments for plaque psoriasis elsewhere in the body, or even pustular, are unsuitable for genital area due to delicate nature of the skin. Tazarotene, dithronol, and phototherapy are generally avoided because they can cause irritation and exacerbate symptoms. Laser therapy is also not recommended. As you know, this can be potentially carcinogenic, and we try to avoid giving that to the patient. Confirming the presence or absence of genital psoriasis is important to prevent patients from self-medicating with the same very potent steroids prescribed to him or her for non-genital lesions. So if you don't examine, if you don't elicit the presence of genital psoriasis, the patient does not offer information, your prescription potent steroids for extragenital lesions may be just what they're going to use. Systemic treatments are indicated for patients with moderate to severe genital psoriasis, or when topical therapies fail. These traditional options may suppress the immune response, however, while newer therapies are also available, as I will show you. A reminder, though, that in 2020, was a Delphi consensus from the IPC that emphasized the importance of considering psoriasis for systemic treatment in sensitive areas, specialized areas like the genitals when determining disease severity. We traditionally assess based on body surface area. And so it is patients with lesions on sensitive areas like the hands, the feet, face, genitals, and scalp, which remarkably impair the quality of life, they can be candidates already for systemic disease, especially if the topicals have failed. Systemic agents include those already approved for plaque psoriasis. In general, though, acitretin is not highly preferred because, as you know, it has a potential to cause dryness and irritation, which is more observed on the genital area and the flexural areas. Aside from traditional systemic agents, however, newer drugs introduced for genital psoriasis are the PDE4 inhibitor, Pramilast, the JAK inhibitor, TYK2 enzyme inhibitor, IL-17 biologics, even IL-23 biologics. I shall discuss this in detail. Pramilast is a PDE4 inhibitor given 30 milligrams twice daily. It was shown to be significantly superior to placebo, however, not as encouraging. The effects are not as encouraging as other systemic agents. Deucravacitinib is a JAK kinase inhibitor. It's more of a tyrosine kinase 2, TYK2, and it is approved by the US FDA and Japan for psoriasis, plaque psoriasis in particular, in 2022. And this is only a retrospective study conducted in Japan, which showed that it is at 6 milligrams it's a day. It is very effective. And they looked at the 24-week response. This is a real-world study, a retrospective one. And they also studied nail and looked at the effect on nail and scalp psoriasis. 6 milligrams once a day using the parameters of SGP, SPGA-G, and DLQI. They found that I'm sorry, it was effective. Okay, so ixekizumab for genital psoriasis. This is an IL-17 inhibitor. This is the first biologic that was tested for genital psoriasis. In patients initially randomized to ixekizumab, clear or almost clear genital skin was achieved in 73% of patients at week 12 and better at 75% at week 52. Persistent improvements were also observed for the symptoms of genital itch and the impact of genital psoriasis on the frequency of sexual activity. The safety profile was also consistent with studies of ixekizumab in patients with plaque psoriasis. There was a head-to-head trial showing the response to ixekizumab and secukinumab of genital psoriasis. This table shows you that the achievement of SPGA G of a score of 1 at week 24 was not significantly different between these two IL-17 inhibitors. The same at week 24, an SPGA of 0 is also not significantly different. So it just tells us that we can use either or. But the limitation of this comparison, however, also was the small number of patients and lack of follow-up. Guselkumab is an IL-23 inhibitor. This is a 52-week observational multicenter study. And again, it was initially 76.5% of patients had already achieved the primary endpoint at this study. And the conclusions was it's effective and safe and may be a valid therapeutic option. Side effects were mild and no serious adverse effects were seen. Bimekizumab is also an IL-17A and IL-17F inhibitor. Again, this is a retrospective, a real-world study involving 52 patients. And at week 24, you see the response is very good, very good. Tildrakizumab is also an IL-23 inhibitor. Again, a real-life retrospective analysis showing you the very good results. They also looked at other special areas like the scalp and the nails, and almost clear skin after 16 weeks. This is a patient actually who had sample, this particular patient in the picture had to stop methotrexate because of transaminitis. This highlights its possible use for genital psoriasis, not just plaque psoriasis. So, in summary, I'd like to give you this final slide. Genital psoriasis has a profound impact on the quality of life and sexual health. And the effective diagnosis and treatments are crucial not only to alleviate physical symptoms, but also to improve overall quality of life. It needs proactive and attentive approaches because of sensitivity to address patient needs. Treatment options have broadened now with the newer molecules discovered, like biologic small molecules and like JAK inhibitors and PDA4 inhibitors. Thank you all for listening.
Hello, my name is Lone Skov, and I'm a professor at Department of Dermatology and Allergy at Herlev and Gentofte Hospital, uh, belonging to University of Copenhagen, Denmark. And first of all, I would like to thank the organizer for inviting me to give this presentation on update on cardiovascular risk in patients with psoriasis. Here's my conflict of interest. Psoriasis is now believed to be a systemic inflammatory disease, and it has been shown that it is associated with a lot of other diseases, especially psoriasis arthritis, which has been known for many years. But in the last 20 years, there's also been a lot of focus on several other comorbidities, and especially including cardiovascular disease and metabolic diseases, including the metabolic syndrome. And in this presentation, I will focus on cardiovascular diseases and the association to psoriasis and especially myocardial infarction, stroke, and death related to cardiovascular diseases. The connection between psoriasis and cardiovascular disease has actually been known for long time. Already back in 1970s, there was published a few manuscripts on the subject, but in 2006, Joe Gelfand published a manuscript in JAMA on the risk of myocardial infarction in patients with psoriasis, and that really started a lot of research into the risk of cardiovascular diseases in patients with psoriasis. We also, a few years later, looked into the Danish registers and found again there was an increased risk of cardiovascular disease, both myocardial infarction and stroke, and also showed that the risks were actually as high as the risk seen in patients with type 2 diabetes. This figure is from the publication from Gelfand in JAMA, and it clearly shows the increased risk of myocardial infarction, especially in patients with severe psoriasis. It's a black dot, but also an increased risk in the patient with mild psoriasis. And it's also clear to see that it was especially the young patient with psoriasis, and especially severe psoriasis, who had an increased risk of a myocardial infarction. Studies from the last 20 years has also clearly shown that cardiovascular diseases and psoriasis have a lot of shared risk factors. It includes hypertension, type 2 diabetes, obesity, hyperlipidemia, metabolic syndrome, smoking, less physical activity, and especially for psoriasis, a treatment and some of the treatment we use for psoriasis, and it's especially including cyclosporine and acitretin. Here's data from a recent meta-analysis showing the increased risk in patients with psoriasis for hyperlipidemia, obesity, diabetes, metabolic syndrome, and dyslipidemia, all showing that there was an increased risk overall in patients with psoriasis, but there was an increased risk from both mild but especially moderate to severe psoriasis. And for smoking, there was an increased risk of cardiovascular diseases in both patients with were active or former smoker. This nice figure is from a recent review in Nature, Review of Cardiology by Gelfand, and it clearly shows many of the shared risk factors, shared inflammation, and also shared comorbidities in both cardiovascular diseases and psoriasis. Due to this finding, a lot of people have, of course, in the last years speculated whether systemic antipsoriatic treatment will impact the risk of cardiovascular diseases. Early epidemiological studies suggest an effect of methotrexate, some newer also a positive effect of treatment with TNF inhibitors. In most of the clinical studies, biomarkers are used as endpoint and they are not validated. There's actually only a few randomized clinical trials with TNF-alpha inhibitors, and they show reduced inflammation in the blood. But looking at the more direct markers for CV risk as vascular inflammation, they didn't show any difference. So if you do find a difference, we also need to be aware of that that if there is a positive effect, it may be different in the different drug used for psoriasis, and that of course especially includes the biologics, but also the newer JAK inhibitors. So we still do need large randomized control with both the old and the new drugs. This is just data from one of the studies which has been published. It's a study where they used vascular inflammation as endpoint, and they look on a large group of patients with psoriasis, and they were treated with either placebo, UVB, or adalimumab, and then they looked at the inflammation by PET-CT, and what they could see was that it has a beneficial effect on psoriasis. The treatments, UVB or adalimumab, has a beneficial effect on the inflammation in the blood. But when they look at the PET scan, there was actually no difference among the placebo-treated, the adalimumab-treated, or the UVB treated before and after treatment. So again, we do not know whether antipsoriatic treatment will impact the cardiovascular risk. What we do know is that psoriasis are depending on certain genes, a chronic inflammation, and several risk factors increase the risk of developing psoriasis. We know also the genes are involved in cardiovascular diseases, the chronic inflammation are involved in cardiovascular diseases, and then there is a lot of risk factor. However, whether psoriasis directly increase cardiovascular disease or whether it's the other way around, that cardiovascular diseases increase risk of getting psoriasis, we do not know for sure, and it may also be a effect both way. Therefore, many studies in the last few years have looked into whether there is a causal relationship between psoriasis and cardiovascular risk factor. In the last few years, several studies using the methods Mendelian randomization have been used to try to look at the causal relation. Mendelian randomization is a method studying a causal effect of risk factors on or by using genetic variants associated with the specific exposure of interest. And there has actually just recently been published a study using the methods Mendelian randomization on a large dataset, including more than 500,000 participants, and looked at genetic predictors of coronary arterial disease and stroke, and found there was a statistical significant association with an increased psoriasis risk. In contrast, they did not find any statistical significant risk increasing associated for genetic predictors of cardiovascular disease and stroke on several other immune-mediated inflammatory diseases, including rheumatoid arthritis and inflammatory bowel disease. This means that the findings suggest that biologic pathway influencing cardiovascular diseases are associated with psoriasis risk, but not with other immune-mediated inflammatory diseases. In other words, that they were specific for psoriasis. An obvious question is therefore, does treatment of cardiovascular disease decrease the risk of psoriasis? But we do not know and do not have studies on this. And what should we then do until we have more knowledge? We shall, of course, inform both the patient and the healthcare professionals about the increased risk in patients with psoriasis. We should either treat the risk factors or refer the patient for healthcare professional which can help the patient with the treatment. And of course, if patients have cardiovascular risk, they should also be treated. And that is in agreement with EULA recommendation for cardiovascular risk management in patients with psoriasis, and also the guidelines from the American Academy and the National Psoriasis Foundation a guideline on care for management and treatment of patients with psoriasis. I have put focus on this because studies have shown that patients included in clinical trial for new treatment of psoriasis are actually often underdiagnosed and undertreated for cardiovascular risk factors. Also, we looked into the patient in Denmark receiving biological treatment for psoriasis, and many of the patients were actually compared to the background population undertreated for the cardiovascular risk factors. We did make a follow-up in a new, just published study, and it seems like we are getting better, but still a lot of patients need more carefully screen and treatment. A new, just published study have looked into the awareness among patients with psoriasis on the cardiometabolic risk. It was only a small survey study, but the patient reported that they were regularly seen by the primary care provider, and they were also in the last year screened and underwent evaluation for cardiometabolic risk factors. However, only 1/3 of the patients were informed about the connection between psoriasis and cardiovascular risk and their increased risk. Therefore, again, it's important that we, as the ones who see the patient, inform them about the risk and take care of sending them to someone who can screen and treat them, or either do it by ourselves. So just to sum up, what we know is that cardiovascular disease and psoriasis is associated. Also, there is a causal relation between cardiovascular disease and the risk of psoriasis, and other studies have also shown there seems to be a correlation the other way around. We know that both the diseases have several shared risk factors, and that we need to be aware of this increased risk of cardiovascular disease when we see patients with psoriasis, and we need to inform them and the healthcare providers about the increased risk. What we do not know is whether if we really carefully treat psoriasis, will it then have a positive impact on the risk of cardiovascular diseases. Also, we do not know if we really take care of the patient are well treated for the cardiovascular disease, will it then have a positive effect on the severity of psoriasis. And if we do find some of this, that it affects the other disease, we need to be aware of that the effect may be very different depending on which kind of treatment we use. And with that, I would like to thank you for your attention. At the pictures is my hospital in Copenhagen, Denmark, but also several of the persons working in my research lab. I would like to wish a nice Congress for you, and goodbye.
Good morning, everybody, and thank you very much for the invitation. I'm Dr. Giovanni Damiani. I'm a professor in the University of Milan, and I direct the Italian Center of Precision Medicine and Chronic Inflammation. Today, I will talk about spatial population and precision medicine. These are rapidly my conflict of interest. Briefly, last year we were talking about special population from a therapeutical perspective. Nowadays, we will focus on some special population from a precision medicine perspective. Okay, let's start from the beginning. And psoriatic disease is a chronic systemic inflammatory disease, as all we know. But in terms of pathogenesis, some advances were achieved in the last decade, but too much is outside to be discovered. Furthermore, we understood that psoriasis, in terms of pathogenesis, have three main sources. One autoimmune, the other one autoinflammatory, and the other one generically we will call inflammatory one. From a behavior of the disease, we can define that chronic, and in particular, we were able to evaluate a relapsing remitting behavior with a deeper sinusoidal movement in terms of seasonality. The systemic nature of this condition allowed us to understand that this disease may trigger with the systemic inflammation other comorbidities such as the cardiovascular one, the pneumological one, the gastrointestinal one, but at the same time, also other diseases such as the cardiovascular one may trigger psoriasis because of the systemic inflammation due to other comorbidities may trigger at the same time also the occurrence of psoriasis. From this perspective, we can understand why this disease, in terms of disability adjusted life years, is among all the tumors, is to the 154 position. And if we take a look to the high SDI countries, so the countries that have higher income, this disease, psoriasis, arrived to the 73rd position. So think to imagine how relevant in terms of economics psoriasis is in the healthcare systems. But what can condition our possibility to treat our patient have two main derivation from biology and from economics. From economics because economics allowed a drug to be sold on the market in the nation. So this is the first step. The second step is also that a patient and the diagnosis of psoriasis most of the time are not plenty healthy. They have other comorbidities that can obstacle the use of the cheaper drugs. For example, the non-biological one, we can name cyclosporin, we can name acitretin, we can name methotrexate. And this case control study was developed from a collaboration between the University of Milan, the University of Padua, and the University of Israel. And that was a case control that enrolled 58,000 people matched for age and gender. And what is the main message? The main message is that at the time of the diagnosis of psoriasis, several comorbidities obstacle the use of non-biologics. So we need to decrease the price of biologics because from a recent point of view, only biologics are able to stop the progression of psoriasis to psoriatic arthritis. At the same time, when we talk about precision medicine, we cannot avoid the definition of a biomarker. Basically, a biomarker is a molecule that we use in order to describe something that is complex, something that is not obvious from a clinical perspective. So we can use to diagnose, we can use to understand how the drug is used, we can use to monitor, we can use to predict the response, we can use to understand the susceptibility, so the risk that an outcome happen. But at the same time, the use of only one biomarker a lot of time is very delusional. Several biomarkers will allow us to understand more and have a higher accuracy in predicting outcomes. And here we are on precision medicine. Precision medicine aims to understand the biological fingerprint of a disease, of a response to a drug, and also is a way that we understand the complexity and we cherry pick the part of the complexity that is capable to help us in the everyday clinical practice. So if we are talking about precision medicine, we deserve a definition also to special population that was really wild in literature because every country define a cluster to a special population because we were talking about people with disability, with family disadvantage, with single parents from a social perspective, homeless, transgender, uh, and other categories. So the definition, we can understand that the definition of the special population depends from the society that we are looking for. So from this perspective, a very heterogeneous definition need a very non-linear use of statistics. So we will move from linear statistics to machine learning that is really important in order to describe and catch a message from the complexity. So basically what we are talking about, if we are talking about special population, a non-linear outcome triggered by a linear stimulus from a mathematical point of view. So we will understand more about that. Let's talk about a special population that last year we didn't evaluate, the alcoholics. The alcoholics are a special population between brackets, but is very, very important because alcohol is an active capable to change the metabolism of drugs, capable to increase the number of flares and the severity of psoriasis. Alcohol is also linked to a decreased adherence to antipsoriatic drug, both biological and non-biological one. And furthermore, a daily use of alcohol is contraindicating also methotrexate and acitretin, decreasing the armamentarium that the dermatologist can use in the daily practice, also in the ambulatory and not in the hospital. There's another really triggering question that was around for so long that finally last year was solved by the team of Professor Loneskov. So alcohol is really triggering de novo psoriasis. From this study, this very large study from the Danish database, the answer was really not. However, despite the alcohol is not able to trigger the novel psoriasis, may act also indirectly because can trigger comorbidities capable to trigger psoriasis. There's no genetical risk of alcohol addiction in psoriatic patients. Could be the only addiction in those patients could be for the detrimental situation in terms of psychology and in terms of lack of help from the society. The only proved polymorphism higher in psoriatic patients predisposing to alcohol was found many years ago in a large Polish sample. From this perspective, we can understand how important will be the genetics and in every population, because the generalizability of the genetics sometimes, especially for risk prediction, could be not a good match. So let's talk about our experience in terms of alcoholics among psoriatic patients undergoing a different therapy. For example, talking about a narrowband UVB and alcohol and med. So UVB is based from the susceptibility of an individual to a narrowband UVB, and so a minimal erythemal dose is the base. Is the base. Talking about the drinking pattern, and after evaluating the pattern with audit, we were able to separate heavy drinker, moderate drinker, not drinkers, so abstemious and binge drinkers. If we were able also to measure how the minimal erythemal dose can change after drinking. So we measured in 2 consecutive days the med without drinking and with a drink, and both heavy and moderate drinker uh, have at the beginning a higher med, so means that they were more protected, the moderate than the heavy drinkers. So the heavy drinkers are more prone to get burnt. At the same time, when we evaluate the second day where those drinkers drink alcohol before arriving, the med decreased a lot, so they were more prone to get burnt. And the same was present in terms of binge drinkers. But what was interesting that binge drinkers that don't have an heavy or moderate drinking pattern don't have big problems in terms of med. So binge drinkers that don't have an heavy pattern don't have really a problem. So why alcohol could do that? Because alcohol can change the release of interleukin 17, modify the subcutaneous structure and function, plus the microvasculature. So let's talk about binge drinkers. As we can see from here, binge drinkers have a slight benefit from narrowband UVB, but it is very significant in terms of terms perception, because we see that binge drinkers and non-binge drinkers, we have a difference, but it's not clinically relevant. But in terms of the LQI, binge drinkers don't have a great improvement of the LQI. So they perceive their quality of life less good than non-binge drinkers. Alcohol finally affects also the final PASI of narrowband UVB with narrowband UVB, because the heavy drinkers and moderate drinkers and even mild drinkers have a higher PASI at the end of the treatment compared to the not drinkers. And that is really important, because alcohol not only condition the life, but condition also the efficacy of not invasive, not immunosuppressive therapies, such as narrowband UVB. Interestingly, we were also triggered by the idea that alcohol and also may be cropped, may be grouped with other addiction in patients. And in particular, we studied the patients that have experienced erythroderma, because erythroderma is a really difficult condition that occur very fast, and in particular is capable to need and hospitalization, and is categorized as one of the emergencies in dermatology. Furthermore, we were able to retrieve some patients, 13 patients with erythroderma. And those patients were administered an interleukin-17 after the differential diagnosis, and 4 of them didn't answer properly to the interleukin-17. We found out that those patients were the patient that have more addictions, at least plus alcohol, some other addictions such as smoking or even cannabis or other drugs. And that was really important because alcohol plus another addiction was capable to decrease the answer of anti-interleukin-17. There's basically, in order to explain this phenomenon, there's basically two main motivation. One, the decrease of adherence, but we evaluate also the quantity of drug into the blood, and they catch the drug. At the same time, also the use of addiction and alcohol plus something else increase a lot the release of interleukin-17. That is one of the main one of the main drivers of the both development and maintenance of psoriatic inflammation. So definitely drugs is something that should be avoided, especially by psoriatic patients, also in order to maintain the responsivity of the drugs and decrease the progression of a systemic inflammatory disease. In conclusion, psoriasis remains a chronic inflammatory systemic disease. We need to have more attention to special population, especially because we are more and more into precision medicine. We are studying the main drivers of inflammation, but we need to understand that psoriasis is a complex disease. Have also some exposures that may modify the pattern of the inflammation, decreasing or increasing the effect of a drug. Alcohol abuse should be detected, should be noted, should be searched and evaluated in our daily practice, because of also some of the drugs that we are using may also decrease the possibility to continue this habit. For example, apremilast recently was nominated in literature for the anti-boozer effect. Furthermore, we need to think that alcohol is heavily conditioning the MID for narrowband UVB and the quality of life. So basically, we decrease the efficacy of narrowband UVB. We have more possibility to burn our patient. And at the end of the day, also if our treatment is clinically very efficient, the perception of our patient is lower than patients that don't drink. Thank you very much.
Hello, everyone. This is John Pauli from Gothenburg, Sweden, and I'm happy to be back at the.
Bonjour. Hello, everyone. I'm Dr. Shweta.